I will show you how you have to use only one side of your glasses to put on the camera. And we will have a 2D. But if you want to follow, you need your glasses. So we are here to understand the vascular anatomy of the orbit. So first, we will see the bony structure, the muscle, arteries and veins, followed at the end by the numerous vascular anastomosis at the orbit level. We start with something we have learned in the university. It's a right anterior view. The nose is here. And we know that we have a pyramidal shape with 4 sides in the front, but only 3 sides in the back at the level of the apex. We can see the tip canal, we can see the superior orbital fissure, separated by the inferior root of the laser orbit. Obviously, the 2 poles have a different axis. Again, a right anterior view. We can recognize the superior orbital fissure, the inferior orbital fissure, and we can follow now the infraorbital groove running in the floor of the orbit at the level of the infraorbital foramen and containing, as you know, the infraorbital nerve, branch of the maxillary nerve, and the infraorbital artery, branch of the IMAX. Here, have a look on the supraorbital foramen or supraorbital canal for the supraorbital artery branch of the ophthalmic artery, terminal branch of the ophthalmic artery, and for the frontal nerve. I continue. The last one with this view. Again, the right anterior view. We have here the pars orbital of the frontal bone, the pars orbital of the maxillar bone, and we can see here the fossa saci lacrimalis, that means the lacrymonasal canal, and the ethmoidal lamina papyraceae, with here the posterior and anterior ethmoidal foramens that contains, as you know, anterior and posterior ethmoidal arteries, branches of the ophthalmic artery. We take the specimen, we are obviously intracranial, the midline is here, and we can see the serrature theca, the right anterior clinoid process, half-widening here the optic canal, the foramen rotundum here for the maxillary nerve, and in the axis, the superior orbital fissure is not visible. So we turn laterally the specimen. So the anterior clinoid process is widening the optic canal. Again, we have the foramen rotundum, and we have here the superior orbital fissure with, in the large part, we know that we have the 3rd, the 6th, and the nasociliary nerves. In the middle, classically, the ophthalmic vein, and laterally here, we have the lacrimal, the frontal, and the trochlear nerve. Again, we turn the specimen. Again, the right anterior view. The nose is here, the optic nerve, and we can see the lateral rectus muscle, the superior rectus muscle widening the levator palpebrae, the inferior rectus muscle and the inferior oblique muscle, and medially the medial rectus muscle and the superior oblique muscle. If you add now arteries and veins and nerves, it's a mess. It's impossible to understand on an anterior view. So we have to perform a dissection to try to understand the anatomy. Again, I turn the specimen. Again, we have a superior right view. The midline is here, with the cristagalli, the cribriform plate, the laser wing, the right ICA, the right optic nerve. The orbit is covered by the dura mater, so we have to remove the dura mater, remove the bone. Okay? We remove the dura mater, we remove the bone. A little part of the bone is here, still remaining, protecting the optic nerve. And through the periostea, we have the fat. So we have to open the periostea, and we open the periostea. In the middle, we have here the frontal nerve. Medially here, the trochlear nerve, reaching or trying to reach here the superior oblique muscle. The lacrimal nerve is not visible. So we remove the fat again and again. And now, again the midline, the periosteum, and the midline, under the frontal nerve, we have the levator palpebrae, and under the levator palpebrae, the superior rectus muscle. Medially, the trochlear nerve, reaching here the superior oblique muscle. We continue to remove the fat and we turn the specimen. Now, the anterior is here, the midline is here, with the internal carotid artery, the pituitary stalk. We can recognize the optic nerve, and we have opened the optic canal largely. We have here largely opened the superior orbital fissure. So we can see here, we can follow the third nerve, the fourth nerve. Here we have the trigeminal ganglion, and we can follow here the ophthalmic nerve, giving here the frontal nerve and the lacrimal nerve. We continue, and we turn a little the specimen, so the eyeball is on the right. Here, the ACA, and in the middle we have the frontal nerve, just over the levator palpebrae and the superior rectus muscle. Laterally, we have here the sixth nerve, reaching the lateral rectus muscle and the lacrimal nerve, ending in the lacrimal bone. Medially, here, the trochlear nerve, reaching the superior oblique muscle and under, just under, the medial rectus muscle. We continue the dissection just to see here the ciliary ganglion, and we know that the ciliary ganglion will give off long ciliary nerves. Again, we have here the fourth nerve and the ophthalmic nerve. This slide, I found this slide in the collection, in the basic collection, and you have this ciliary ganglion on the superior view, giving here the very long ciliary nerves, reaching here the eyeball. We have to consider now the ophthalmic artery. And we start by the origin, classically originating from the Mercier at the level of the junction C6, C7. Obviously, superior view, pituitary stalk. The hypophysis is hidden by the dura mater, the two subnerves, and as you can see, the ophthalmic artery is originating from the medial aspect here of the ICA. Again, only on the right, we have cut here the optic nerve, so we can see the origin of the ophthalmic artery, and in the majority of cases, this origin is in the subarachnoid spaces between 83% to 100%. We can see now the different part of the ophthalmic artery. Again, the midline, we have pushed here the optic nerve, so we can follow the artery, and we can describe here the intracanaliculaire part, where the artery is under the nerve, passing from medial to lateral. Then we have the intraorbital part with three parts. First, the first portion is a straight continuation of the intracanaliculaire part. The second part is the artery cross above or under the optic nerve, above in 70% and under in 30%. And the last part is the part where the artery runs medial in the orbit and follows the muscular medial wall with the nasociliary nerve. We have now an example of an artery here passing under the nerve and giving here the lacrimal artery. The same specimen on the lateral view, posterior, and the origin, junction C6, C7. We can follow in the optic canal here the ophthalmic artery, separated from the nerve by a layer of fibrous tissue, and having here the first segment in the orbit, the straight segment passing under the nerve. In the majority of cases, the artery passes over the nerve. We have here a specimen, we have cut the optic nerve, but we can guess that here we have the second part here of the ophthalmic artery in 80% of cases, and the third part followed by the nasociliary nerve. We have to speak now about the central retina artery. The central retina artery reaches the optic nerve classically 10 to 15 millimeters from the posterior pole of the eyeball on the ventral aspect. It can arise directly from the ophthalmic artery, or it can arise from a long ciliary artery. When it arises from the ophthalmic artery, classically it arises at the junction between the first and the second part. And it's classically the first branch arising at the beginning of the second part, or at the end of the first part. So we have here the lacrimal artery, so ophthalmic artery, and the origin here of the central artery of the retina. When it arises from a long ciliary artery, again, the long ciliary origin is at the junction between the first and the second part. That means that before the artery passing over the gland. The lacrimal artery now is one of the largest ones. The microphone is not working.
It's working.
So we continue with the lacrimal artery, originating from the ophthalmic artery, but we will see it can originate directly from the middle meningeal artery. And this artery is one huge artery in the orbit, supplying the muscle and reaching here the lung. We follow now the ophthalmic artery with the ciliary nerve. This artery will pass classically between the superior oblique muscle and the medial rectus muscle. And it is in the third part, before the end, we will give off the two anterior and posterior ethmoidal arteries. To see this artery, we have here to separate the superior oblique muscle from the medial oblique muscle, and we can guess that we have here the posterior ethmoidal artery, and here the anterior ethmoidal artery reaching the anterior and posterior foramen. Again, the posterior ethmoidal and the anterior ethmoidal. This artery, as you know, it's a superior view after minification. The midline is here with the cristagalli, the cribriform plate, the nasal fossa. We are on the roof of the nasal fossa, so we can follow here the posterior ethmoidal artery running on the roof of the nasal fossa to reach here the cribriform plate. And on this superior view of the cribriform plate, on the midline, we can see the anterior and the posterior ethmoidal arteries, obviously branches of the ophthalmic artery. The posterior ethmoidal artery is supplying the posterior part of the cribriform plate and the surrounding dura mater of the anterior fossa. While the anterior ethmoidal artery will give the falcine artery. Here we can follow, and this falcine artery here along here the dura mater has possibility of anastomose with the medial branches of the middle meningeal artery. We have to consider now the end of the ophthalmic artery. Classically, after giving the superior and inferior palpebral arteries, anastomosing with the lacrimal arteries laterally, the ophthalmic artery divides in two branches. A superior branch, the supraorbital artery, passing in the supraorbital groove and supplying the forehead. And a second branch that has been cut here, the supratrochlear artery, passing over the trochlea of the superior oblique muscle And on this anterior view, you have recognized the nose, the orbit, the superior trochlear artery, giving here the dorsal artery of the nose and ending in anastomosing with the angular artery, which is the end of the facial artery. Another view. Here, the supratrochlear artery, giving the dorsal artery of the nose and anastomosing here with here the angular artery. We have a magnification. If we diminish the magnification, we can follow now the facial artery, ending here in angular artery, anastomosing with the supratrochlear artery. We continue now with the vein, and we know that the ophthalmic vein, the beginning of the ophthalmic vein, is made by the fusion of the angular and the frontal vein. Near the trochlea, again, trochlea is here, at the junction between the straight, the two parts of the superior oblique muscle. So we have here this vein rolling back and crossing the orbit to reach here the superior orbital fissure. This superior orbital vein or ophthalmic vein receive tributaries from muscles. It's important to consider that the vein you have seen here along the optic nerve is hidden by the muscles. So the vein is covered by the levator palpebrae and the superior oblique muscles. If we remove the levator palpebrae and the superior oblique muscle, we can follow the superior ophthalmic vein, receiving here tributaries from the muscles, receiving here the inferior ophthalmic vein. We have here the junction, and this vein pass in the largest part of the superior oblique muscle or at the junction between the large and the narrow part. We have just to see now a specimen, a cast, and we will see the right side. We can see here the optic canal with the ophthalmic artery and the ophthalmic vein running back here in the narrow part. On the contrary, on the left side, again we have the optic canal with the ophthalmic artery, and the vein is at the junction between the large and the narrow part. So, as usual, we have a variability with the vein. This vein now will drain in the cavernous sinus. So, we have a left lateral view. Anterior, posterior. We have removed the dermater. We can guess that we have in red the ICA. We have here the superior orbital fissure. And entering the cavernous sinus, by the superior orbital fissure, we can follow the ophthalmic vein. And we know that this ophthalmic vein can drain posteriorly via the superior pectoral sinus, the inferior pectoral sinus, or medially on the basilar venous plexus toward the foramen magnum. But this venous component, this venous blood, can also drain inferiorly using the foramen lacerum and the foramen ovale to reach here the pterygoidal venous plexus surrounding here the arimax, and after draining directly in the internal jugular. We have to consider now the variation and possibility of anastomosis. Have a look on this specimen, a right side. The midline is here. This is the ophthalmic artery. And we have here the middle meningeal artery passing through the superior orbital fissure and supplying here the lacrimal gland and the lateral rectus muscle. There is no communication here between the ophthalmic artery and the middle meningeal artery. So the orbit can be supplied only by the ophthalmic artery, but also by the ophthalmic artery and the middle meningeal artery. And these two arteries can be totally separated, or they may have some anastomosis. We have here, classically, a meningo-lacrimal artery. That means that it supplies the lacrimal gland and only the lacrimal gland and the muscles. We know that this artery, the meningo-lacrimal artery, can enter via the superior orbital fissure or used another hole, the irritable hole, classically, the irritable foramen, outside the superior orbital fissure. Now, we know also that we may have anastomosis between the meningo-lacrimal artery and the ophthalmic artery. We are here on the left. We have opened here the superior orbital fissure. We can follow here the middle meningeal artery, giving so here the lacrimal artery and anastomosing with the ophthalmic artery. Another specimen again on the left with the eyeball, the optic nerve, the ophthalmic artery, and here the middle meningeal artery entering and anastomosing here with the ophthalmic artery. We know that we may have other variation. Have a look here. Obviously, we have the Mercier, the superficial temporal artery, and this is here the middle meningeal artery arising from the ophthalmic artery. Now, another variation. Dissection, the midline is here, it's a superior view. The eyeball is here. We can follow here the optic nerve. We have largely open here the superior orbital fissure. So you can recognize on the midline here the hypophysis. The right here, Mercier, the nerve, the trigeminal nerve, the trigeminal ganglion. And if we separate the optic nerve from the Mercier, we are looking for the origin of the ophthalmic artery. And there is no ophthalmic artery. All the supply arrive from the middle meningeal artery, entering here via the superior orbital fissure. This variation is then the meningo-ophthalmic artery. I am sure you have seen this angio with insult. And here we have no ophthalmic artery. If we continue, we have here a retinal blush, and that means that the total supply of the orbit is coming from the middle meningeal artery. We continue with the anastomosis. The midline is here, right anterior view. And if we follow this artery, the infraorbital artery, this artery will give through the infraorbital groove anastomose with the ophthalmic artery. So this anastomose can pass through the infraorbital groove or using here the lacrimonasal canal to reach here the supraorbital artery. The same after magnification. We know that it's possible also to have anastomose through the zygomatic bone. It's a posterior view. We are again on the right, with the right zygomatic bone, and here the lateral part of the inferior orbital fissure. Here we have small foramens, bigger foramens, and if we practice dissection, enrich the artery in blue the veins, we have removed a part of the temporal muscles, and we are dissecting branch of the deep temporal artery, and these branches are passing through the zygomatic bone to reach the orbit. They can use directly through they can pass directly through the zygomatic bone or use the inferior orbital fissure. Again, another specimen with here the infraorbital fissure or directly through the zygomatic bone. If we turn the specimen, we are on the left, we can see one artery passing in the inferior orbital fissure or passing here through the zygomatic bone, and after magnification, it's more obvious. Again, imagine now that the superficial temporal artery can pass through the anterior aspect of the zygomatobone, and again, with possibility of anastomose with the lacrimal artery. And we can follow if we dissect here the anastomose. We have also the possibility of follow the transverse facial artery passing through the zygomatic bone. One of the last possibilities is the anastomose between the supraorbital artery and the superficial temporal artery. We have seen this slide this morning. We can follow the superficial temporal artery, reaching here the supraorbital artery and supplying the orbit. The last possibility we will see with the cavernous sinus is the ALT. We have lateral view of the cavernous sinus on the right, posterior, anterior. We have removed the lateral part of the cavernous sinus. So this is the third nerve, the fourth nerve. This is the ophthalmic nerve. And at the junction between C4 and C5, we have the origin of the reality, giving here, we will see later, the anteromedial branch, following the ophthalmic nerve, passing through the superior orbital fissure and supplying the orbit. And we have here this anteromedial branch supplying the orbit. To conclude, remember that the ophthalmic artery, the middle meningeal artery, the infraorbital artery, the deep temporal artery, the superficial temporal artery, and the reality can supply the orbit through many anastomosis. Thank you very much.